Hello class, my name is Jacob Kidwell. I'm a new nurse with about a year worth of experience on medical surgical unit at Hillcrest Memorial Hospital in Fredericksburg, Texas. At this point in my career, for me personally, this project was a great experience to get me more involved and really help initiate a positive change in my facility that as a new nurse, not all individuals have the opportunity to do so. That being said, here's my Nursing 456 Practicum Process Improvement PowerPoint. For my Practicum Process Improvement, I selected my facility's current emergency department inpatient stay process. The decision to improve upon the admissions process came from multiple factors, including, but not limited to, a lack of current standardization in the process, allowing for widely varying experience, no current continuing education / process improvement initiatives, creating a stagnant and outdated model, a clear need and change expressed by the frustration experienced interdepartmentally between the emergency department and inpatient units, and lastly, due to the high volume of patient admissions, any change for the better will have a cumulative effect over time on both patient and nursing experiences. Having identified the patient admissions process as the area of need, moving forward, I wanted to have a clearly defined goal for my interventions. My goal for the practicum process was to design, implement, and evaluate improvement to the current emergency department and inpatient stay process, focusing on the improvement and continuation of care and patient outcomes. This goal will be achieved through a sequential progression through 3 phases revolving around the intervention-based changes and their outcomes related to nursing satisfaction. Phase 1 of 3 was the design, and as such, I wanted to not only make changes, but to find the areas most needing attention in the current system and apply the best evidence-based practice methods to improve them. My first step was the peer interviews, along with an associated survey to gauge the satisfaction of currently with my peers, as well as identify feedback for possible solutions and suggestions they might have. Next, I conducted an evidence-based practice review on 10 credible articles related to the admissions process and educational material to get a better grasp on realistic and proven changes conducted in similar situations. After completing my evidence-based practice review and peer suggestions, I took my data to the throughput committee meeting in early August. This group offered me a unique opportunity to fast-track my interventions, as it comprised of managers, charge nurses, and staff nurses from all units involved in the admissions process. It was at this meeting that, having mentioned my peer comments and overall satisfaction 7 out of 10, that collectively we were able to identify interventions moving forward. They were improving communication, staff education, and systematic future changes as areas to address with my in-process improvement work. Starting in late August and early September, I went about holding peer education sessions. Close to 20 members were trained in all. These sessions were aimed at addressing the interventions identified during my committee meeting. During my training, I discussed misconceptions between departments, such as the emergency department dumping patients during their inpatient nursing shift change, which happened to happen 1 hour before that of the inpatient units, inpatient delay in assigning rooms / nurses, which should have always been done 3 nurses ahead, 3 rooms ahead, which was causing subsequent delays in the ED shipping patients out times, which their goal was 30 minutes from the time the admission orders were signed. Handoff discrepancies at the bedside, from inaccurate reports to misassessments and medications, and reinforcement of teamwork between the units to promote a positive work environment. We're all working together. Along with the communication points, we reinforced interventions of the 15-minute ED call ahead. This gives the inpatient nurse time to prepare for the new admit. The call ahead was already in place, however, was not being practiced thoroughly and had been getting missed on frequent occasions, with patients showing up to units unannounced and inpatient nurses scrambling to admit them. ED nurses also starting all medications and fluids per protocols ahead of admission, for example, the sepsis protocol with antibiotics and associated fluids. More comprehensive and accurate handoff reports, along with inpatient nurses taking time to read up about the patient prior to handoff to increase effectiveness of the care team, as a second set of eyes can catch errors and add suggestions to current therapy. Lastly, the ED prepping patients for admissions prior to shipping them. Gowns, IV access, making sure patients were clean, ready. These simply yet pivotal requirements can delay an inpatient nurse with an already busy schedule to have to go back and can now conduct rework that could have been done prior to transport. In conjunction with this training, I also asked our peers about possible future changes, systematic ones, revolving the matrix. Again, we currently staff to our current levels, which the issue being, it does not always allow for, if we have a sudden inflow of patients, for us to really catch up with that. We have to call in a nurse, which delays the inpatients leaving the ED up to the emergency department, slows them down. So we wanted to go ahead and see if we, instead of staffing the current volume, staff 2 ahead. And if they had any suggestions as far as the handoff sheets, to go ahead and do something similar to that of PACU, the operative report were given during their transfer, which could help create a standardization and overall facilitate a faster process. Having completed the interventions and peer education starting in October, I moved into the evaluation phase of the project. To get an understanding of the success of the interventions, along with have a method of comparison to pre-intervention values, I again conducted peer surveys. However, this time, along with the original questions of ranking satisfaction as 0 to 10, listing any possible suggestions for process improvement, and sharing any personal experiences, both positive and negative, with the process, I added a specific question relating back to the perceived success of the interventions and training conducted during my implementation phase. My responses were very positive for the most part, with many individuals citing a noticed improvement over the past month, along with bringing up those who were questioned the first time what we did to try to address their concerns during the first meeting, and if they felt like our solutions had improved in those areas. They mentioned personally. Lastly, again, I brought up the future improvements the committee was now considering to get a feel for how individuals perceive their need now compared to that of pre-implementation phase. Both were still identified, the handoff sheet and the staffing matrix, as needing to be improved upon, and moving forward, they were something we were going to pursue. Reflecting upon the process, it is almost hard to believe that it's come to an end, and it's a very rewarding and immersive experience. I am personally very glad to have had, we were able to achieve success in our improved communication interdepartmentally, and a moral and improved morale and efficiency. We also have seen a marked improvement relating to 15-minute callouts, medication administrations, the quality of the handoff reports at the bedside, all of which would help the patient and nurse's satisfaction experience. If I had to do anything differently, I would possibly have tried to implement the standardization handoff report sheet during my practical experience. Due to the time constraint and having to train / follow up on staff compliance, it was something I felt difficult to do in the 5-week window. And I felt the benefits of the handoff sheet would best be displayed over time as nurses incorporated it into daily practice more efficiently. Moving forward again, to reiterate, we are currently taking talking to management on the inpatient nurses side to see if we can adjust the matrix to provide the staffing cushion. We do believe having a staffing cushion will not only help reduce the occurrence of nurses having to operate at max patient loads very frequently, but prevent delays in admission due to having enough nurses to receive patients despite open rooms was one issue. Also, the handoff report sheet is currently being developed again using the PACU model. We are tailoring one to the ED specific. For example, patient diagnoses, medications given, tests run, patient history, and then situation background, what brought them in, currently what methods are we doing to help with the therapy. I hope all of you enjoyed my nursing 456 practicum experience, and that some of you even may be able to apply what you've learned here in your own practice. Thank you for your time, and good luck with your professional careers.